anyhow, this video is we are trying to demonstrate how you have to sprinkle it. Next slide कर दीजिएगा अगर नहीं चल रही तो कोई नहीं. Okay, reboot कर दें, no issue. So this basically this slide is this video is trying to demonstrate that how the ribbon should be made. It should be a micro ribbon. It should not be a wider ribbon. Why is it important? We will see in the next slide. The important thing is that when you this all is going to come, but I am just trying to continue. When you inject fat, there are three zones of the fat. One is the central zone. Let me move forward quickly. Okay, so this is how you have to inject, and the area where it is most important you would see. Now this area is the most delicate area, periorbital area. Here any lump or bump is not forgiven. So here you have to be very careful, and this is most important lesson to learn. Wherever you are fat grafting, try to consider that skin as if you are injecting in the periorbital area, so that you never lose your precision. Now this is important. Post-graft care, people have recommended immobilization. Some people have used botulinum toxin to immobilize the muscle. The more mobile the area is, the more would be the absorption. We have already seen this in lips and in other areas that the more mobility is there, the more would be the. So you can use neurotoxin. Now this is where Professor Mahmood Sabah Chaudhary and his role comes as a teacher for me. So this is what we have published in February 2022, that insight into the fat graft pre-enrichment strategies for improved survival. Still there is 10 to 90% variability. After following all this, after getting a training, if you are initially your absorption rate is 90%, with all these techniques, you follow them, you rigorously do the fat grafting, you are experienced, you may reach up to absorption of 30% rather than 90%. So your success rate may be 70% fat would survive. In my, personally, when I do fat grafting, about 70 to 75% of my fat graft would survive, but 25% would absorb after following all these protocols. So it means we need something else to improve the survival. Now this is the theory I was talking about. You can see that everything has to receive its blood supply from the surroundings. So this is the fat droplet you have injected, and this is a small droplet, and you can see these vessels can reach to the center. But here this is a large fat droplet, and the blood supply would not reach to the center. Okay. Here you can see this is a micro ribbon, it would survive. This is a macro ribbon, it would not survive. Now here comes the role of overfilling. The blood supply is coming from the surrounding. The area is already tight. If you overfill it, even if the small ribbon would not survive. So you should never overfill. Just optimum filling. And how would you do optimum filling? Compare it with the opposite side. If both sides have to, then you have to use your clinical equipment. Now this is what I was talking about, three zones. This is the zone, necrotic zone, this is the regenerating zone, and this is the surviving zone. Now, if we can increase the blood supply, we can convert this necrotic zone into regenerating zone. Or we can convert this regenerating zone into surviving zone. Okay? So if this zone contains stem cells, because stem cells are resistant to ischemia, relatively, their nature is that if there is ischemia, they would survive in the ischemia, but the adult adipocytes would not survive. So if we can add stem cells to our fat graft, survival would be better. Okay. This is a typical case where we have done fat grafting. This is the picture after 1 week and this is the picture after 3 months. Fat has absorbed, simple fat grafting. So what we have already been doing, regrafting. Ask the patient, I will do a session of fat grafting. After 3 months, you will come to me again. I will again do a fat grafting session, and this you will achieve in about, from starting from here till here, you will achieve in maybe 3 sessions or 4 sessions. Okay? So here is the role of stem cells. So adipose tissue-derived stem cells are relatively resistant to ischemia. So if we add it, then it would survive. So why this is important? So these are the reasons why should we use adipose tissue-derived stem cells. Easy, straightforward, and you can easily harvest them, abundant supply, and there are no problems, and there are minimal donor side morbidities. This you have already talked about. I will only say one word about SVF. SVF is a two-edged sword. It can work in a positive way, but it may not work in a positive, may not, because there are many cells in it which are not pro-regenerative. Okay? Professor Musaba has already talked about this, that about many cells are not pro-regenerative. This has already been explained by Professor Musaba that once you have prepared the SVF, then you can expand and you can get an expanded pure population of stem cells. That is ethically not allowed. But in our study, we got a special permission from POTA, and we did, in our study, we used expanded stem cells. We prepared the SVF, then we cultured those stem cells, and then we had about 3 or 4, maybe 6 passages we used those expanded stem cells in our study. This is what our study was, and it has been published. Professor Fridoon, Professor Musaba, they were both my supervisors in my PhD, and I'm really grateful for their contribution in enhancing my knowledge about stem cells and being a part of my journey in my clinical career. These are the representative cases. Again, you can see this patient had 2 sessions of fat grafting. This is simple fat grafting. This patient, multiple sessions, but compliance is poor. So I came to know about this, that compliance was poor. I was overfilling. We should never overfill. Stem cell group, again, stem cell group, single session, single session, single session. Now the problem was that this study completed, and now what to do? Patient would come and would ask you, Doctor, stem cell ka aap study kar rahe hain, kya kar rahe hain? So as a clinician, we have to think what else we can serve. So now what we are using is that, we are using a cocktail that comprises of microfat, nanofat, and PRP. Why we are using microfat as a filler? Why we are using nanofat? Probably there are studies which have proven that nanofat does contain more stem cells than the microfat. So probably we are trying to add stem cells to our microfat graft. And why PRP? Professor Musaba taught me that when you will culture these cells, you would need plasma, you would need serum. So I thought if it can work in the lab, it should work in human body. So I started adding PRP to all my fat grafting procedures. Now there are 2 ways to prove things. One is to first prove it and then use it. The other way is use it, and if it is effective, then go back and try to prove it. As clinicians, we don't try to go back and prove it. So it is working. Sir, Madrat ke saath. This is always a debate between me and Professor Fridoon. But someday we may prove it. So, few applications, few representative cases. All of these cases, I have used the cocktail. In few cases, I have used SVF, but most of them, because the SVF expanded stem cell was limited to that study. This patient comes to us with this fat atrophy and with concerns about probably the under the eyes. And then she brings this picture and said that, okay, Doctor, can I be improved to this extent? So this is what I follow with my fat grafting protocol. I use only the intraoral incision, and these are the different areas which you have to fill. This picture I have taken from one of the papers published from Japan, and I was talking about should the fat graft contain blood. All these patients, they did dry technique of liposuction for fat grafting. The picture you see, that was full of blood, but the results were there. So what I want to stress upon is that if fat graft contains blood, it doesn't affect the outcome. Don't worry about it, but you have to prepare it more thoroughly. So this is the marking we do, preoperative marking, and these are the results about 6 months, and this is the result maybe after an year. So one of the presenters was presenting in a meeting, and she said that the fat which we inject doesn't grow with age. It does grow. Now the patient says that, would it stay there? I said that if you will gain weight, it will, the volume would increase. So this you have to tell the patient. Again, another patient. So these pictures were sent by the patient. This is basically a difference between an educated patient and uneducated patient. So I just messaged him and I said that I have to make a presentation, so send me your pictures. So he said, I have gone to a photographer, I have asked him take my pictures in these views, and I am sending you. Okay, so this is one patient. And this is another patient. I said, send me your picture, and he would take a selfie with a filter. Okay, and we'll send you. The results are not that dramatic, but they have improved a lot. But this picture is with a selfie, with a filter. Again, another patient, I asked her to send the picture, she would send this picture. This patient has periorbital rejuvenation. But the important thing is that things improve. When patients send you a picture like this, it means they have started liking themselves, and they have started kind of coming back to their feeling motivated, feeling better. Again, another patient where we have used fat for periorbital rejuvenation, breast augmentation we commonly use. Now, these days there are many problems with implants. Import is banned. There are problems with escalation in dollar prices. So fat is a very good option for those patients who want breast augmentation. What next? The best view comes after the hardest climb. So this is my journey. So this journey is incomplete if I don't mention patients who have actually taught me all this and whom I am proud of. This is one patient, I treated it with cocktail. This is a post-burn scar, and this is the result with simple PRP and Nano fat. And obviously, if we can inject expanded stem cells, probably the results would be much better. This is another patient. She had this bad trauma. We did a flap and then we did skin. But at the end of the day, we had to do fat grafting. So these are the patients which really encourages you to move forward and keep on learning from teachers like Professor Mustafa, Professor Ridoon, and try to improve yourself. Exosomes, sir, I am not going to talk about in detail, but the important thing about exosomes is there are many regulatory issues with the stem cells. Exosomes probably would cover that bar, and you can use exosomes, you can import exosomes, you can prepare exosomes, because the reason being that there are no problems with what I am going to say. Probably there are no markers on it. Professor Ridoon will talk about it in detail, but as a clinician, I see a lot of potential in exosomes. So these are the various indications of potential uses of exosomes, and these are the references, and this is my message to all of you.